mix. Like, for example, some of us like to, when we're in a presentation, some of us like to be writing, making notes, and to me, it helped reinforce what I'm learning. Okay, how many people are like that? Okay, 1, 2, 3, 4, 5. Great. So we have this all three learning, because the PowerPoint presentation and my speaking will incorporate all of that. Now, before we also go any further, I just want to also ask, there are 5 people in this room have been in Reno for at least 3 to 5 years, right? So what I wanted to know was, how many people have had patients with some form of bone or kidney disease? And could you also tell me what kind of symptoms did they exhibit to you? Okay, let me hear. Okay. Yeah, okay, what kind of symptoms did your patient have? Joint pains, yeah. And mobility, they were having, okay. Great, thanks. What about you? Okay. And did they have any swelling of the joints? Yes. Okay, great. And what about muscle cramps? Yes, because these are all things that are symptoms of bone disease for our patients that we have come across. Thank you very much. Another thing is, as we get into it, and as I'm going to start the PowerPoint and just kind of give you an overview as to what is it that will be expected. Now, the objective of this PowerPoint and this presentation is basically to prepare the nurses, and I should ask, how many of you here is just here for review in preparing for the CNF, and how many people are here just for, you know, information, gaining new information? Okay, 1, 2, 3, 4, 5. Great. So 5 people are writing the CNF, and I wish you guys all the best. And I'm hoping that today, after we finish this presentation, you will be able to gain some understanding and some more information and clarifications for things that you have not come across, or, you know, that way when you're writing the exam, it might prompt your memory back to this presentation. Okay? Now, like I said before, our objective today is just to give you the specific points to help prepare you for the CNF. And upon completion of this presentation, I'm hoping that there'll be some heightened awareness of renal osteopathy. I'm so sorry. I can never pronounce that word. Please forgive me. Nurses also will be able to identify any abnormal lab values that are showing up when a patient has got some kind of bone disease. And you will be able to know what are some of your nursing intervention. And also, you will be able to demonstrate some clear understanding of renal osteopathy. Sorry, I'm going to just refer to it as bone disease, okay? So, sorry about that. Okay, now, since we are all aware of the fact that these are the function of the kidneys, okay? It's to stimulate and to regulate active vitamin D, which is involved in regulating calcium, phosphate, and parathyroid hormones, right? And so now I'm just going to go through exactly what takes place. The kidney and the vitamin D you need the UV radiation in order to activate vitamin D when your skin is exposed to the UV ray. And this is a precursor for vitamin D to convert by influence of the parathyroid hormone. Okay, and vitamin D, once the parathyroid from the kidneys is activated, it activates the vitamin D, which gives you calcitrol. Okay, now calcitrol helps the body absorb calcium, right? So with that in mind, the other name for calcium is calcitrol is 125 dihydroxyvitamin D3 or 125 dihydroxycalcitriol. And calcitriol promotes calcium and phosphorus absorption from the intestines. Yes. So, and also, it also promotes the incorporation of minerals into the bones. Keep that in mind because as we get further into our presentation, you will see just how effective that is. Calcitriol also helps maintain normal parathyroid hormones. Now, when we have kidney failure, of course, the kidney stop working to convert to inactive vitamin D to calcitriol. So therefore, there's an inability to excrete phosphorus and it's accumulates in our bodies. The body is unable to absorb calcium from the intestinal tract and it borrows the calcium it needs from the greatest calcium storage deposit, which is, of course, everybody, you can tell me what that is. What is the greatest calcium storage in our body that the kidneys would take the calcium from? Come on. Guys, you're all renal nurses. You can tell me that. Okay. Yes. The bone. Yes. And of course, when you see the calcium is being drawn away from the bones, we're going to have a decrease in the formation of active vitamin D, and in kidney failure it leads to osteomyelitis. And that's when we have our patients, like you told me earlier, that your patient is going to have pain, joint pains. And of course, something else that I've noticed too with our renal patients, if they have a bump, like if they hit themselves against anything at all, they are going to end up with a broken bone, which means that there's not enough sufficient calcium in the bones that will be able to get them to not to break so easily. This picture on the PowerPoint is just showing you what a normal bone looks like, and then what the bone that is decalcified, that does not have enough calcium in it. And as you can see, the holes in the bone is not very good. Is a lot different than this one. Okay, so our kidney. I'm not gonna go through all of that again. What I wanna draw home right now is to inform you that, just to pinpoint what is it that we're trying to say here. Chronic renal failure causes increased serum phosphorus and vitamin D. This results in serum calcium, in decrease in serum calcium. Okay? And then when you have a low serum calcium, it triggers the increase in the PTH, right? And then when you have the PTH increase, calcium reabsorbed from the bone, which is you end up with secondary hyperparathyroidism, contributes to renal osteodystrophy. And with that, you're going to have secondary hyperthyroidism, also attribute to anemia and the development of cardiovascular disease, which is another topic that a lot of our renal patients have. Okay, now just to kind of summarize, earlier when I asked you to tell me what kind of things that your patient showed to say that they have these renal problems, renal bone disease, a lot of you mentioned bone pain, a lot of you mentioned muscle cramps. Also, another thing, a couple other things I should throw out there to you is that they also have bone deformities. They have an increased risk, like I mentioned earlier, of fractures. Like any little bumps, they'll create that. They have a poor mobility, and they have numbness and tingling. And with increased phosphorus, oh, sorry, I should back up there by saying that the numbness, the tingling, and the muscle cramp is caused from a decrease in calcium. And when you have an increase in phosphorus, it triggers itching of the skin and hypocalcemia. Like a lot of us that have been in renal for so many years, we have seen a lot of these issues with our patients. So just so that we are aware, we keep a watch on the patient's lab results. And the patient lab results, usually the serum calcium level should be between 2.12 to 2.62. Okay, now just to finish up, come to a close, treatment, you keep the phosphorus below 0.87 to 1.52, okay? And then when you, with the control of dietary phosphorus restriction and phosphorus binders medication, this will help to maintain the proper level of the phosphorus in the patient. Now, patients are given medications like Renagil and Lantus carbonate. They cannot be given aluminum phosphorus. So just to keep that in mind when you're looking at your exam. Now, I just want to recap from what we have said earlier. Vitamin D is involved in regulating calcium phosphate and parathyroid hormone levels. And calcitriol helps maintain normal phosphorus levels. Restoring the balance between calcium phosphate and PTH is the goal of the treatment. And just for your memory, remember that aluminum hydroxide is very toxic to renal patients and should not be given